Thank you, Dr. Tapas, for making my work a little bit simple that I'm going to discuss about. As you said, lately the examination has become more challenging, which I completely agree and support also because we deal with the sickest patient in the whole hospital and our um, what do you say capacity and our knowledge does count for a better outcome of patient. And EDIC is a special international exam. The degree is recognized in many, many countries, particularly the European countries. So, to give a standard to the exam, the quality of question have increased. The threshold of knowledge required to pass the exam has increased also. Um, so, usually in the exam, they come with three CCS and they look at covering most of the domain of critical care. I write it here as 11 domains, but that's our thought process that we have the whole course material um, described or whole course material covered in 11 domains. But there are some overlapping things. There are some domains also which are very special that we classify and give more importance to that. So the whole syllabus of EDIC 2 per se, we divide in our course into 11 domains. So I talk from that perspective. I'll try to show you that how the three CCS that was been asked in the last exam has not left any of the domain untouched. So as Tapas was talking about, it is the breadth and the width of the knowledge that they are trying to depth and the width of the knowledge that they are trying to assess in this exam, and it is becoming more and more challenging every year. Now, as we are discussing here that we are no way we can talk about the exact question because we don't have it, but whatever information that I have is based on our students who have appeared the exam, like last batch of students who have passed on. They have given us information that these questions were asked, they faced the particular difficulty in this domain, and I wanted to summarize all of them. I will not per se discuss about any particular question, rather than I will show you how what are the things that is been asked. And the focus of this webinar is to tell you that how varied the questions can be in this exam. Answering these questions like what are particularly asked is pretty easy for us to discuss, but that should not be the aim of this discussion. I wanted to highlight what sort of knowledge base that you should have to appear this exam. Now, the Tapas was talking about the pattern. Now, it's very hard to comment on the marking pattern in the exam, how they mark. But what we have seen over the years that these are the fixed eight pattern that each CCS goes through. Usually, they will give a vignette, the case vignette, saying that you have a 28-year-old male who had a road traffic accident and he has this type of finding in terms of the blood test. This is his imaging, this is his vitals. And as a opening question, they may ask you to summarize the case. What do you mean by summarizing the case is to give a gross idea, the big picture of the whole scenario, what you understand by reading the stem. So that's the case summary they ask for. Next, they expect you to know about some differential diagnosis. Okay. We'll talk about this as the course progresses, but they are very keen on looking at what are the other things that you are looking at as a ICU specialist rather than focusing on only one territory. Like suppose somebody is hypotensive with trauma, it's not always hypotension due to hemorrhage. The shock can be multifactorial. Similar thing, they want to see how your brain works in having a rational differential diagnosis. Then the pattern usually goes to what is your immediate priorities? What are the things that is going to kill the patient? And as a able ICU specialist, how can you prevent it or how can you treat it? So immediate priorities. Then the vignette gradually progresses to a next step where they will give you some new information about the progress of the patient, about the complications that has happened, or some sort of new investigation they will show you, and they will ask you to interpret what is wrong with the patient, because this is not face to face exam with a patient at the bedside. It is more of a exam which you will be conducted in a virtual scenario, but they plan to make it as practical as possible. So that's how the usual ICU rounds happen, and they try to just try to copy that type of pattern. So they will give you a pattern of investigation and ask you to interpret, and then ask you what is your definitive management. This is important because the definitive management have to be very specific. As a ICU specialist, you cannot fluff around with it, and there is a grid to mark. The grade again for the marking is designed in a way that you need to talk about the most important 4 or 5 things that is going to decide the patient outcome. If a trauma patient who is bleeding and you don't talk about resuscitating the patient with blood product along with a um, point of care coagulation study like a rotum guided transfusion, then that will mark you less compared to someone who talks about it. Okay, if you don't talk about definitive measures of control of bleeding, including surgery or early surgery, and also looking for drugs like tranexamic acid, and you don't know about the current evidence and current recommendation, that will again mark you negative or less mark. If you keep on repeating the things that he's being already asked in the immediate priorities, like the airway, breathing, or circulation in the definitive management, then again that will be a demerit to you. So there is a way, or there is a pattern to answer, and this only comes if you keep on practicing. That's what we focus in our course. We do more than 20 CCS practice over the next 3 months in the course, so that these way of answering of all these scenarios or all these vignettes come automatically to you. You practice before you face the music. Okay. Now, in the sixth step, they again talk about some complication that the patient has encountered, and they assess how do you manage, or first of all, how do you find, or how do you evaluate the patient and to know what is the complication, and then how do you manage with your escalation plan. And lastly, but not the least, they talk about your communication skill. They will give you a scenario where the patient will be deteriorating, or there will be some iatrogenic complication that has happened. How do you talk to the relative? How do you break the bad news? What is the way to talk about some important points that is marked in those grid to give you the pass mark, or if you don't perform well, you may not pass it. So the essence of this slide is, this is the common pattern. Like these 8 steps, they usually go one by one serially, so it feels like it is a real case. And in fact, the cases that is brought into the exam are actually real cases in some ICU. Okay, now for example, last time, as I said, the exam just gone, they talked about a neurotrauma or a polytrauma patient. They they um, they they asked about initial trauma assessment and how, what is your resuscitation plan. They talked about how do you manage a hemorrhagic shock patient, and they talked about or asked about damage control principle, which is very core for a trauma resuscitation. The patient happened to have a thoracic trauma, and with a complication of bilateral hemothorax, pneumothorax, had some chest strain, required some massive transfusion, and they also asked about interpretation of a E-fast ultrasound. So you can see how the vignette turns on itself and ask you progressively, which is a common ICU scenario. Then this patient also had spinal trauma, and you require surgery for this patient. So they talked about what is the timing of surgical intervention, early versus late. What is the first priority, whether to fix the spine or encounter or address a life-threatening injury to the patient. If the patient has a concurrent TBI and a spinal injury, how do you manage? Then the things turned to a refractory ICP management. The patient had a raised ICP, and what are the options for that, including hyperosmolar therapy, evidence around it, decompressive craniectomy, what are the indications for that, and how do you counsel the family for this? And also ICP monitoring they did ask about. Again, that went to the prognostication after traumatic brain injury and how do you talk to the patient. So it's a comprehensive vignette that is asked in the exam. Okay. Similarly, if you say, okay, this is the CCS, a trauma patient is going to be asked about only neurotrauma or anything regarding neurotrauma. It is not, because there are three CCS and they try to mix all the system or all the domain that I talked about, all the 11 domain that we think into this three CCS. The patient previously being asked a cerebral vascular sinus thrombosis, a hemorrhage, or a venous sinus thrombosis with hemorrhagic transformation. In those cases, they presented with seizure. How do you manage the seizure? They give you a CT scan, how to interpret a CT scan. Again, interpretation of CT scan is a very important part in the exam because you'll face that question both in CCS and in CVS. In usual practice, you have 10 minutes to sit down and have a look at a CT scan in your usual ICU rounds for 10 minutes and then you can make an impression. Unfortunately, in this exam, you only have 1 minute to talk about it. So it's unnatural to have a CT scan get interpreted in 1 minute. Even the radiologist would not be able to, but you are expected to do that in the CBS. So you need to know how to address such question, how to look at a CT scan very quickly, and what are the common thing that is being asked in the exam. Okay. There are scenarios where they asked about anticoagulation in a cerebral venous sinus thrombosis patient. How do you approach whether you anticoagulate that patient or not? What is the role of catheter thrombectomy? Then again, that scenario then progressed to a decompressive craniectomy. We talked about the TBI part of things. Then again, it's not stopping in there. There was another vignette where there is a patient who suffered a stroke because of a prosthetic valve and an atrial fibrillation as a complication of endocarditis, and they kept on asking about how do you manage a AF patient? What are the contraindication and indication for thrombolysis? Management of embolic stroke. What are the toe indication? How, when do we do a transthoracic esophageal ultrasound for a patient who have a stroke or who have a endocarditis? What are the indication? What are the contraindication? What are the complications of a infective endocarditis, such as splenic infarct? The patient had a splenic infarct in one of the questions. How do you manage it? How do you manage a prosthetic valve in infective endocarditis? So when do you do the surgery? When you manage conservative, what is the outcome of that? What are the common organisms involved in that type of infection? So these are being asked in three CCS. They can assess anything they want, right? And they are very practical oriented. Questions from hematology transfusion, they had a rotum and you need to interpret how the rotum is and what is your plan for this patient. What are the indications for fibrinogen replacement? What are the indications for platelets cryo replacement? What are the current evidence behind use of tranexamic acid in trauma and other disorder in a bleeding patient? So importantly, the rotem is a very, very important aspect of this exam, and you need to know in and out of that and should be able to quickly interpret. We focus on multiple rotem in various vignette in this course, and also during the mock test, we give a practice for this, so which will enable you to interpret and answer quickly. Again, 1 minute for each CBS. This last edit also covered questions from GI, renal, CRRT within that three CCS. There was a question about somebody had a abdominal surgery who had a post-operative shock requiring CRRT. So how do you select which modality of CRRT? Again was a question. What are the complications of regional citrate anticoagulation? That was a question again. How do you write a CRRT prescription? We go in extensive depth about this in our renal domain where we talk about the whole CRRT, what are the possible questions that can be asked. There was a patient with hyperammonemia in the EDIC exam, which was again asked, and how do you manage and what is the role of CRRT or renal replacement therapy in hyperammonemia, that was being asked. Similarly, infection and sepsis is a big part. Again, the last EDIC had a lot of questions from that. Had a vignette of influenza A with toxic shock syndrome with a necrotizing infection. How do you differentiate a shock? So we have a session on shock in one of the CCS that is being discussed or will be discussed in one of the domain. How do you differentiate between different 5 types of shock? What are the important things to look for? This helps you to give a differential also in the exam. You remember I told about the 8 points. The second point was a differential. If you know how to evaluate a shock, you can give your differential in a graded manner in the CCS. Then there was some vivas about staphylococcal toxic shock syndrome. How do you manage it? How do you escalate the antibiotic and appropriateness of the antibiotic? There may be questions on antibiotic stewardship, which we do talk about in one of the module. There was, as I said, there's a vignette of post-operative ICU patient who developed VAP. What are the scoring system of VAP being asked? Patient had a CLABSI. How do you define CLABSI? And also other source identification in the sepsis. There was questions on respiratory system, mechanical ventilation in one of the 3 vignettes, which talked about ventilator weaning. How do you wean? What are the criteria of weaning failure? Hypoxemic respiratory failure, ARDS management. Question was on prone ventilation and also on ECMO that can be asked. What are the targets of oxygenation in a patient who is hypoxic? What sort of oxygen you target? And a little bit of evidence behind it, whether you hyperoxygenate or not, all those questions being asked. Similarly, the patient who was in the exam, they talked about hemodynamic optimization in the post-operative period. Then lactate physiology was also asked in the exam. Somebody with a liver failure with a high lactate, what are the causes of high lactate being asked? Family counseling, prognostication part. This was a question. How do you prognosticate and counsel the family for a patient who has a traumatic brain injury and very low chances of survival or survival with significant disability? How do you approach those situations? It was a question there. Again, this has crept up in recent EDIC exam. They asked about advanced modality of investigation such as ultrasound, transcranial Doppler, trans esophageal echocardiogram, thoracic ultrasound, um, like specific echocardiographic features of pulmonary embolism, tamponade, pericardial constriction, etc. This has been asked, and this time they asked about EFAST. We talked about that, how to interpret a CT brain or any associated imaging of the brain quickly, and toe and thoracic ultrasound being asked. So we have sessions on this in one of the modules that we talk about. So that was a summary of the CCS that was being asked, the 3 CCS that was being asked this time. You can imagine how broad the question can be, and they try to cover the whole of the ICU concepts in these CCS. And whatever is left, they don't leave it as such. You will have to face a multiple CBS also, which one of my other colleague will be discussing after me. But the impression that I want to make with this presentation is the knowledge that you need to have going into the exam is really quite a lot of knowledge, because it is an exam where you are being evaluated as an ICU specialist in a country or in a region who practices ICU in a different way compared to what we come from, like what the other part of the world come from. So the expectation or the bar for this exam is pretty high, which I can understand and I can rationalize why it is. And we need to be doing something out of skin to pass this exam. Okay, but it is not impossible, and we do help out with this. But again, the major determinant for passing successfully is your practice and how much well read you are. We only shape up your preparation by our course, but we cannot impact if you are not interested, if people are not engaged in the whole course, then it is very difficult to steer them through the exam. Just I'll briefly describe the structure of the course, and then I will stop my presentation. So if somebody enrolls to our course, how do we help them? We initially start with a Zoom introductory assembly like that we are doing today. We explain the course framework. We explain what is expected from the candidate, what are the responsibilities of the faculties, and we talk about the module structure. The module structure is there are 11 module that we have divided the whole course into, and each week or around 10 days we try to enroll one module so that we go step by step. We give access to study material for each module. The study material again is being revamped this year with more current articles which are readable, not like giving you 10 articles on pulmonary embolism because you are not going to read them. You will find only one or maximum two article on a topic, on an important topic, which is readable, like very small summarized article rather than talking about a guideline of 50 pages on pulmonary embolism, which is readily available in the internet. You can get it. But we focus this time on very succinct study material, which already being revamped this year so that this can be helpful to you in any ways. So you get the access to our articles, which is called as the Tricks Cloud. The module starts a week prior to the mock exam for that module because it will give you some time for pre-reading. Then on the day, on middle of the week, sometime Thursday probably, we give you a link for a mock exam. Again, this exam is very, very important. Each module will have two CCS and around 15 to 20 CBS to practice. We ask our candidate to appear this exam very, very seriously in a time bound manner. People do neglect this, saying that, oh, we can read, we can look at the recording. Yes, there is always a backup. You can always go for the video recording and have a look, but the feel and the practice that you get sitting in the exam scenario is really, really important, because you'll not get the time management if you don't appear those exam. And you please, if you are enrolling, don't push it all, I'll do it in the next module or do it in the next module, because the time is short and it will pass away very, very quickly. So from day one, module one, the maximum number of people that can enroll into these mock exam, the better it is. You need to at least do out of 11 8 or 9 module to have a good practice. We have seen people who have appeared this mock exam repeatedly, religiously. They had a good result compared to others. They are more confident in answering these questions because I believe whoever is appearing the EDIC exam, the knowledge base is almost the same. All of you have practiced the EDIC intensive care for a few years now. So the knowledge base is more or less same. But the main limiting factor is how you project it to the examiner, and more practice will help you. Right. So you get a online link to appear the exam, and then on Saturday or Sunday there will be a debrief of these questions. We talk about the ideal answer for this question, give you tricks and tips, how do you approach, how do you change your approach if you have done in a way, and also provide important study tips in terms of what other questions can be asked, what has been asked in the past, because only one question will not do justice to that domain. We look for more questions we discuss. Okay, now this time what we have done additionally is um, so after 11 modules, you will have two mock tests. This is the full syllabus mock test. 11 plus 2 is 13 mock test with two CCS. So around 25, 26 CCS you will do. The additional thing that we have done this time is we are providing access to some particular CBS videos. So what we'll do is each week we'll send you a list of 10 possible topics of CBS and ask you to vote which are the 3 or 4 most important topic you want us to explain in a short video. So we'll make around 3 or 4 short videos around 10 minutes length of each to make sure that at least those CBS topics are covered in addition to whatever you are doing. Like 20 times 11 is around 200 CBS will be done, or more than 200 CBS will be done in the whole module test, but this is in addition to that, to have a comprehensive knowledge. Plus we'll give you access to another 24 CCS from our previous year questions that again will be provided as mock, and you can appear on your own time and look at the explanatory video for that, along with another set of more than 400 CBS questions. So if you look at the numbers, you will have around 24 new CCS scenarios. You will have around 200 plus new CBS of this time. Plus you'll have double the number of CBS and CCS as from our repository to appear those exam and practice, and also look at the videos for them. All right. Um, so that's after enrollment, that's how it will run. But anyways, the focus should be to maximize the effort that we put in this course by participating in the mock exam, by participating in the debrief. That's what is expected from the candidate. And if you do it very positively, I don't think there is a reason why you should not pass. We do a comprehensive review, whatever we can, to the maximal possible effect that we can do, and provide you a lot of practice to get through this exam. So by this, I will stop my presentation and ask Dr. Niharika to do the CBS part of the recall questions. And if you have any other questions, please feel free to put it in the chat box, and happy to answer, or any of the faculties will answer. Thank you.